As we have mentioned, in early onset bacterial infection, pneumonia is invariably present. X-ray chest should be obtained to determine the presence of pneumonia. If it shows infiltrates, it may suggest diagnosis, but these infiltrates cannot be distinguished from those resulting from other causes of neonatal lung disease. Presence of a pleural effusion makes the diagnosis of pneumonia more likely. So, what is the definitive diagnostic tool? A positive bacterial culture from blood, CSF, or any other body fluids, as urine, is considered a definite diagnostic tool for bacterial sepsis. This is called a culture-proven sepsis. This will be further explained in the face-to-face session. Because of the high incidence of early onset neonatal sepsis and GBS nowadays, it's crucial to have preventive measures, especially if a predisposing factor is present. Don't delay treatment till confirming the diagnosis. It's enough to have a clinical worrying signs and suggestive investigations to start treatment. Then treatment can be modulated according to further investigations. Prevention of early onset neonatal GBS infection has been achieved with intraperitoneal administration of penicillin given more than 4 hours prior to delivery. The current guidelines is to perform a vaginal and rectal GBS culture at 35 to 37 weeks gestation in all pregnant women. Prophylaxis with penicillin or ampicillin is given to GBS positive women, to those who had GBS bacteriuria during the current pregnancy, to those who had a previous infant with invasive GBS disease, and to those who have unknown GBS status at delivery with risk factors for infection. As we have mentioned, the presentation of neonatal sepsis is subtle and can be easily confused with other diagnoses. So, a high index of suspicion is important in diagnosis and treatment of neonatal infection. Infants with risk factors like rupture of membrane more than 18 hours, maternal chorioamnionitis, prematurity, need to be carefully observed for signs of infection. The duration of treatment for proven sepsis is 10 to 14 days of intravenous antibiotics. In cases with meningitis, duration shall be prolonged. It may require 14 to 21 days. Antibiotic therapy should be tailored according to age of onset, clinical setting, and initial findings. In the early few days of suspected diagnosis, before proving the diagnosis by positive culture results, a broad-spectrum antibiotics should be given according to the commonly occurring organisms. Antibiotics will be changed later according to the result of the culture. For early onset neonatal sepsis, which is usually caused by GBS or gram-negative enteric organisms, broad-spectrum coverage should include ampicillin 100 to 150 mg per kg per day divided every 12 hours, plus an aminoglycoside in a dose of 3 to 4 mg per kg per dose every 24 hours based on a gestational age at birth, or third generation cephalosporin like cefotaxime 100 mg per kg per day divided every 12 hours. For late onset neonatal sepsis, coverage may need to be expanded to include staphylococci. In particular, the preterm infant with an indwelling line is at risk for infection with coagulase-negative staphylococci, for which vancomycin in a dose of 10 to 15 mg per kg every 8 to 24 hours, based on gestational and postnatal age, is the drug of choice. Initial broad-spectrum coverage should also include a third-generation cephalosporin if Pseudomonas is strongly suspected, or an aminoglycoside. To prevent the development of vancomycin-resistant organisms, vancomycin should be stopped as soon as cultures and sensitivities indicate that it's not needed. In sick infants, the essential of good supportive therapy should be provided, like IV glucose, nutritional support, volume expansion, and pressors as needed, oxygen and ventilator support. Meningitis is the most serious infection in neonates. Never forget that any newborn with bacterial sepsis is at risk for meningitis. The incidence is low in early onset neonatal sepsis and higher in late onset neonatal sepsis. The presence of seizures should increase the suspicion for meningitis. If the neonate has suspicious signs of meningitis, a lumbar puncture should be done because blood cultures can be negative in neonates with meningitis. Diagnosis is suggested by a CSF protein level higher than 150 mg per deciliter, glucose less than 30 mg per deciliter, leukocytes of more than 20 per microliter, and a positive gram stain, and is confirmed by positive culture. Meningitis requires 14 to 21 days of antibiotic therapy, and sometimes more. Gram-negative infections, in particular, are difficult to eradicate and may relapse. The mortality rate of neonatal meningitis is approximately 10%, with significant neurologic morbidity present in 1/3 of the survivors. Early onset neonatal sepsis is usually associated with pneumonia. Pneumonia should also be suspected in older neonates with a recent onset of tachypnea, retraction, and cyanosis. In infants already receiving respiratory support and increasing the requirement for oxygen or ventilator support, perhaps with a change in the character of tracheal secretion, may indicate pneumonia. Infection of the urine is uncommon in the first days of life. On the other hand, urine should always be evaluated as part of the workup for late-onset neonatal sepsis. Urinary tract infection in the newborn can occur in association with genitourinary abnormalities. That's why evaluation with an ultrasound examination is important. Neonatal UTI is usually caused by gram-negative enteric pathogen or enterococci. Culture should be obtained either by suprapubic aspiration or bladder catheterization. A normal umbilical cord stump atrophies and separates at the skin level. A small amount of purulent material at the base of the cord is common and can be minimized by keeping the cord open to air and dry. The cord can become colonized with bacteria that can cause local infection. This is called Omphalitis. Infections are more common in cord manipulated for venous or arterial lines. Local and systemic cultures should be obtained. Complications as septic thrombophlebitis, hepatic abscess, necrotizing fasciitis, and portal vein thrombosis may occur in severe cases. Surgical consultation should be obtained because of the potential for necrotizing fasciitis. It's also prudent at this point to add anaerobic coverage with metronidazole. Neisseria gonorrhea may colonize an infant during passage through an infected birth canal. It presents at day 3 to 7 of life with copious purulent conjunctivitis. Prophylaxis occurs with 0.5% erythromycin ointment. Infant born to mothers with non-gonococcal disease should also receive a single dose of ceftriaxone. Chlamydia trachomatis is another important cause of conjunctivitis, appearing at day 5 to several weeks of age. Treatment is with oral erythromycin for 14 days. Topical treatment alone will not eradicate nasopharyngeal carriage, leaving the infant at risk for the development of pneumonitis.